Good afternoon and a warm welcome, everyone. This is via MedGenome, the leaders in genetic diagnostics in India. So today's webinar is a continuation of our genetic education series from laboratory to bedside. So we are doing this in association with the Genetics and Fetal Medicine Committee at FOGSI. And this is the fourth webinar in a series of 7 webinars. Today's topic is on reproductive genetics. The agenda for today's talk is an introduction to the series by Dr. Mandakini, welcome address by our chief guest, Dr. FOGSI Lewis, the Vice President of FOGSI. And then we have 2 speakers lined up today. We have Dr. Priya Kadam, Director of Reproductive Genomics at MedGenome, who will talk to us about non-invasive prenatal testing. And then our second speaker is Dr. Meenakshi Lallar, who is a consultant geneticist at MedGenome and Prime Imaging Chandigarh, who will be talking to us about the genetics of infertility. Now, I would like to request Professor Mandakini Padan to, welcome, give an introduction to this series and take this session forward. Over to you.
Yeah. Good afternoon, everyone. This is the fourth in the series of genetics webinar organized by FOGSI Genetics and Fetal Medicine Committee. We are thankful to our Vice President, Dr. FOGSI Lewis, to take out time from his busy schedule to join this webinar and bless us. He is the aim of this series is to make OBGY practitioners introduced into a topic that is upcoming, and probably next 5 years, all of us have to learn genetics to have a good clinical practice. And that's our aim to start this, the series of webinar. And today's talk is on reproductive genetics. That is, lot of us are practicing infertility. Then initial part of it, we do not know how to screen for the chromosomal abnormality in the fetus, that is Down syndrome, the commonest one. And then the NIPT has come in a large way. So the cost of these genetic tests have decreased drastically over the years, and hence accessible to many of the patients. So we should be aware about these and then introduce this into our routine practice, what we used to do it. So I have got the privilege to introduce Dr. FOGSI Lewis, our FOGSI Vice President. He is in charge of Genetics and Fetal Medicine Committee. That's the committee that I am chairperson. He is basically, he is a very good teacher of obstetrics and gynae, knowing everything about this, what is going on and what is our future, that how to create a new subject, new chapter, new course introduced into our practice. Was ISAR National Executive Member, ICOG Governing Council Member. So hence, Indian College of Obstetrics and Gynecology being a member, he knows into the details of what is running in our FOGSI and our ICOG. He was Secretary Kerala Chapter of ISAR, Vice Chairperson of Kerala Chapter, Executive Member of Kerala Chapter. So he has lot of past experience of it, and above all, he is a very kind person to encourage everyone to go ahead and do all these webinars, transmit knowledge, and make people accessible to all these webinars so that it becomes informative and people can have access at their leisure. So I welcome you, sir. I thank you for coming and joining, and hope you will bless us so that our webinars goes fine. Thank you. Over to you.
Good afternoon to you all, respected Mandakini Madam. I think it is a proud privilege to be here in a fetal medicine and genetics webinar. And as you all know, the Madam is the Mandakini Madam is the chairperson of the Genetics and the Fetal Medicine Committee. And on both the genetics and fetal medicine, if you look into in detail, compared to the other clinical topics, it is little tough, and those who are really interested only can and deliver the job. I think Madam has been into so dedicated and made this committee activities into so vibrant that that focused information is being given for the practicing clinicians today for reproductive medicine. As you all know that a lot of infertility centers are coming, but how far genetics plays a role, I think, and in fact, Madam was telling just before the starting the meeting how the genetics is important in the with her own experience a few years back. So even this is my field of interest. I'm into reproductive medicine. We are also having MCH course by MCI recognized MCH course. So we know the importance of the genetics in the reproductive medicine, and also the NIPT part. This is part time of the parcel of the precious pregnancies. Nowadays, if there is a genetic difference, parents will be wanting to know about the baby, and people are very much concerned about the invasive procedure. So, but the evidence and the importance and how far we can rely on the NIPT. I think today's speakers, especially NIPT by Dr. Priya and genetics in infertility by Dr. Meenakshi, will be highlighting that. And I congratulate the Fetal Medicine Committee headed by Mandakini Madam for bringing out this series of topics like genetics from laboratory to clinical practice. And even the genetics is you can feel that it is such a not so active type or vibrant type topic. It is a little dry topic. But those who are genuinely interested will know about it, how far it is significant. And Madam is trying to put that in convey that interest into the practicing clinicians so that it will be very useful for their practice and for all the patients whom they see. With this, I wish all the success for this wonderful webinar on the reproductive medicine and genetics and the reproductive medicine. Thank you for inviting me. Thank you.
Thank you, Dr. FOGSI, for that. This thing. We then start on to our webinar first talk, and I request Joseph to introduce Dr. Priya. Or I have got the privilege to introduce Dr. Priya. Okay. So sure. I learned many things from Dr. Priya. I must confess at this thing. Though the genetics is changing every day, to keep pace with the changing knowledge, technology, I have an amount of discussion with Dr. Priya, and she guides us, makes us understand what is this report says. So she is MBBS from Bangalore Medical College and have got a Master of Science by Research in National University of Singapore. She has patents in US and China for her work in prenatal testing. So she has a medical background and a lab background. And here is she talking on NIPT so that we can, from the lab, we can take this testing onto our day-to-day practice, that is bedside. So I welcome Dr. Priya and thank you for speaking to us on this topic. Over to you, Dr. Priya.
Thank you, Dr. Mandakini. That's really very encouraging. I'm touched. And welcome all of you to this session. It is our fourth part, and I'm actually looking forward to speak to all of you because I want to kind of clarify many of the things that that you might not be aware of, or some of the questions which you might have in your mind about NIPT. I've been with MedGenome for about 6 to 7 years, and we have set up the non-invasive prenatal testing in India, the whole lab process. And with thousands of samples, we have gained a certain amount of experience, which I'd like to share with all of you. So the way I'll structure my talk is I will speak about the background of NIPT. Most of you may be aware, but there are certain key points which it is useful to go over and remember. We will speak about utility of NIPT in clinical practice. Some of the key discussion points. I have 6 interesting cases that we have analyzed in the lab, and there are certain aspects which they highlight. So those are what I want to talk about basically in this webinar. We will talk about the frequent questions that we are asked, especially about sensitivity of NIPT in twins. What are the limitations and challenges which you should be aware of when you prescribe NIPT? And some basic guidelines on what should be the best practices so that you get the most out of your NIPT test. So as we all know, we are living in this pandemic. It is abating, so that is good news in some parts of the world. And so NIPT, we saw that saw an uptake during the pandemic because of the way that it is the way it functions. It is safe, it is non-invasive, and one of the most important factors is that it reduces the number of invasive procedures which are required and the hospital visits. Okay, so these are the main important things, and when you have a low risk NIPT report, it gives reassurance to the parents, which is the high negative predictive value. So as obstetricians and gynecologists, all of you must be aware that screening has to be provided to all pregnant women in some form or the other. We know that it was maternal age first, then there was serum screening, and now NIPT. So the importance of screening cannot be emphasized enough. And we also know that India, with its large population, has a large burden of these chromosomal disorders, given the natural incidence also. If you have about 1 in 166 live births with an abnormality, if you look at the total burden per year, it would be about 1.5 lakh abnormalities or abnormal children born because of chromosomal abnormalities. Now, very important for all of us to know, most of you will be aware, what is the difference between a screening and a diagnostic test. So screening test should be such that it can be applied to a large population from which you will pick out individuals which actually need further testing. And these can then be offered a diagnostic test, which will tell you for sure whether the individual has the disorder or not. That is yes or no. NIPT is a screening test that we should always remember, and it just alters the risk. So your risk before, given your situation was this, you did an NIPT, then your risk increased or your risk lowered. So NIPT is a screening test which gives you a risk of having a chromosomal abnormality. Now, what are the testing options which are available antenatally? We know that there is maternal serum screening with some ultrasound and NIPT in the screening test. And amongst the diagnostic test, for you would actually need some amount of fetal material or fetal DNA. You might do a chorionic sampling, you might do an amniocentesis, and then the lab procedures which are actually done are FISH and qFPCR, karyotyping, or chromosomal microarray. I will actually go into each of these from my cases, where you will see the relative importance of each of them. And when you look just at the screening test, why does NIPT perform better? The reason is that from 9 to 10 weeks onwards, you can actually offer the test anytime. You are not bound by the gestation period, as is for first trimester screening and for quadruple screening. It has a very low false positive rate compared to the maternal serum screening, and we can now look for more and more conditions with NIPT. But having said all this, ultrasound has a very important it's very important during antenatal screening, and that is because you need to know many factors even for doing an NIPT. You need to know whether you're looking at a singleton pregnancy, you're looking at twins, or you're looking at a vanishing twin. So you need to know, and also if there is a gross abnormality, you wouldn't want to go in for an NIPT. You might want to do diagnostic testing directly. So that's why ultrasound has a very important place. And many times people ask us, what is a good time to send a sample for NIPT? We usually recommend that after the NT scan. It's around that time where you already have information about the fetus, and it's also an appropriate gestation age to get the result with enough amount of fetal fraction, and also enough time for you for further testing. So what is non-invasive prenatal testing? Basically, it is testing the cell-free DNA from the maternal blood during pregnancy. And the most common abnormalities that we look for are trisomy 21, 13, 18, abnormalities of the sex chromosome. Certain tests can look for triploidy, microdeletion syndromes, rare autosomal trisomies, and also RHD factors, some single gene disorders. Okay, then it is safe and it is non-invasive because you're only taking maternal blood. So now we know that during pregnancy, from the fetus, you have different material which actually comes into maternal blood. So there may be a fetal cell, there may be a DNA, there may be RNA, all these from the fetus. And it is this DNA that we are currently interested in when we do the cell-free DNA testing. Now, there are certain factors about this cell-free DNA we should always remember is that it is a combination of maternal cell-free DNA and the fetal cell-free DNA. So it is actually a combination. Physical separation is not possible so far. It is mostly a digital separation. There are various ways in which it is analyzed. And it comes from the placenta. This point is also very, very important because it can have implications for false positive and false negative results. And it is usually you see about 5 to 25% of the total DNA is cell-free DNA, and that it clears rapidly after birth. So what that means is that when you're testing a pregnancy, the result that you get pertains to the current pregnancy. Now, since NIPT has been available from 2011, several international committees have come up with guidelines. So initially, they recommended that this test only be performed in high-risk individuals. So by high risk, they mean those which were high risk on conventional screening, like first trimester and quadruple screening, or those who had abnormal ultrasound markers, or those who had a previous history of a chromosomal abnormality or advanced maternal age. But as the amount of testing increased and people saw how it performed amongst general population as well, they finally came up with suggestion that it be offered to all pregnant women. So as one of the screening methods. And then the choice of the patient, of course, with cost and all those factors involved. And in 2016, actually, the group from SGRH came up with the guidelines for India, or the recommendations which we can use for India for NIPT. Now, how has NIPT performed? As you can see, it is about a decade since NIPT has been available. When you see this graph, you see the uptake in the number of tests, and this graph actually shows the decline in the number of invasive procedures needed for gross chromosomal abnormalities. So we know that NIPT test is available all over the world. Now, coming to what has been our experience so far, or how, which is actually a reflection of how it is done in India, we see that most of the cases, about 24%, the maximum number, come for high to intermediate risk on maternal serum screening. So it is used as an advanced screening test before they go in for an invasive procedure. And then the other common indication is advanced maternal age. Sometimes we see other ultrasound abnormalities, and sometimes there is no clinical indication given. I would actually request all obstetricians who send samples to actually give some indication on why you are doing the test, because it helps in compilation of data, which helps all of us. So I just want to summarize the major advantages here, and then we can go into individual cases. So the high detection rate compared to other screening methods, low false positive rate, reduction in the number of invasive procedures, the high negative predictive value, which helps avoid invasive procedures, and also the risk that is predicted is independent of age. Now, when this test came in, you always compare it with what was there before. So this analysis actually is a very good starting point. In 2015, this paper was published where they compared the standard screening, the various parameters on standard screening versus cell-free DNA testing. So for trisomy 21, you can see the sensitivity difference, you can see the specificity difference, and the major difference that you see is the positive predictive value. So if the positive predictive value with standard screening for trisomy 21 is 3.4%, with cell-free DNA, it is 80.9. So I'll come to what that actually means. Similarly, for trisomy 13 and trisomy 18, the difference is between 14 versus 90 and 3.4 versus 50. So what does this actually mean? What it means is if you have 100 women who have tested high risk on first trimester screening, 3 of these will be true positives. That means the fetus will be really affected with Down syndrome, while 97 of them will have normal fetuses. Okay, so if you do an invasive test with high risk on NIPT screening in 100 women, 80 to 91 of them would actually be affected. So when you get a high risk on NIPT, the fetus is more likely to be affected than not. Okay, so the procedure that you do is actually useful. So that is what is the positive predictive value. Having said that, I mean, this is just one example where everything was normal in the antenatal time, scan was normal, triple marker was normal, but the baby was born with Downs. So that is an example of false negative. Some of you might have heard of these situations or might have come across this in your own practice where you find everything normal during pregnancy, but the baby is born with Downs. So when we first established the test, just to understand how well it will perform in the Indian scenario, we actually performed a study of about 516 women. There were 10 centers across India, including SGRH, PGI JIPMER, PGI Chandigarh, JIPMER, then there was Manipal and Amrita Hospital. So we worked together we had a protocol actually on how to administer the test. So we had a follow-up data of about 94 to 95% of women who were actually followed till birth or the logical end of the pregnancy. And our data was very much comparable to other published studies. And the positive predictive value, as you can see here, was also just as expected. So this is the major advantage or the strength of NIPT, in which your positive predictive value will be high and negative predictive value will also be high. I mean, so far, I'd like to share that we have not had a single false negative. I mean, theoretically, it is possible, but that is one of the benefits of the test. Now, what has been our data? So when you send samples to us, we collate data together sometimes, and this is what we see, that as expected, most, about 97% will be singleton pregnancies, about 2.4% are twins. And when a NIPT is sent, about 94% would be a low risk result. About 2.5 will be high risk, and about 1 to 2% we would ask for a redraw. Now there are, redraw is something which you should be aware of and maybe just mention to the patient also, because that helps in compliance later on when a redraw is requested. Though the redraw rate is low, this information given to the patient always helps in compliance later on. And the reasons for redraw can be pre-analytical reasons, like sometimes a lysed sample reaches us, sometimes the sample volume is too low, and sometimes it could be post-analytical factors in which there may be low fetal fraction or a QC failure. Now, if you send a sample again for pre-analytical factors, most likely it's going to work. But if you send it for post-analytical factors, when there is low fetal fraction or QC failure, the likelihood of getting a result on a redraw is about 65%. So you should be aware of this. This is a common figure. We can give specific figures based on specific data, but that is a ballpark figure, about 60 to 65% you will get a result on a redraw. So if you're very close to about the legal limit for termination, it may be better to go in for invasive testing if the fetal fraction initially is too low. Then, as expected, of course, trisomy 21 is the most common disorder that we find, and followed by trisomy 13, then trisomy 18. And sex chromosome abnormalities are all about 20% of abnormalities. And we've had the privilege actually to offer NIPT across two platforms, the SNP-based platform and NIPT, the Claria counting platform. They have their advantages and pros and cons actually. So the call rate with NIPT, the counting method is about 98%, and with SNP-based is about 93%. Redraw rate was slightly higher with the SNP-based method because of certain inherent things. And as you can see, rare autosomal aneuploidies and CNVs above 7 MB can be screened by this method, not screened by this method. And with twins, the counting method actually offers certain advantages in terms of zygosity and also individual fetal fraction, even it is a dizygotic twin. Now, let's come into some of the case scenarios so we understand how NIPT is being used and some of the special cases. So this is when they come for intermediate risk. I mean, not even intermediate, this risk 1 in 1610. So this patient, about 38-year-old, who had conceived spontaneously, 13 weeks, 2 days of gestation, showed this risk. But when she came in for NIPT, NIPT actually was high risk for trisomy 21 with a very good fetal fraction of 8.7%. And as with any high-risk case, it has to go in for invasive testing. They went in and a QF-PCR test actually confirmed the result that it was trisomy 21. Genetic counseling was done and they decided to discontinue the pregnancy. Now, coming to the second case, this was a couple who were 30 and 31-year-old. Their previous pregnancy on 19 weeks, 2 days had actually shown bilateral choroid plexus cysts. The quadruple screening was low risk. But when the baby was born, it seemed abnormal and the child actually showed trisomy 18. It unfortunately expired at 6 months. So next time when they came for testing, they had researched and they figured out they had, in between, they had also done karyotyping test of both the parents and they were normal. And second time when they came, they specifically looked for NIPT because of its higher detection rate, and the next baby was normal. I mean, it showed low risk at 10.5% fetal fraction, and the follow-up is that they are parents to a healthy baby girl. And no further investigation was done in this case. So the takeaway from case 1 and 2 is that ACOG in 2020 guidelines say that cell-free DNA is the most sensitive and specific screening test as of now. And we have gone over this comparison between standard screening and cell-free DNA, and sensitivity also is much higher than the standard screening. Now, one other case which I'd like to share was a 32-year-old woman. She was in a non-consanguineous marriage, spontaneously conceived, and first trimester screening was normal. She was actually categorized as low risk, but many times patients come in asking to do an NIPT. So the clinician had sent this sample, and she turned out to be high risk for monosomy X. Okay, so the fetal fraction was very good, 10.5%. There was a lot of counseling which recommended that she go in for invasive testing, but they terminated the pregnancy without testing, which is very much not recommended, but we see that happen. Okay, and the product of conception, actually, they did want to know what was wrong. Was that a real result? So they went in for a chromosomal microarray of the POC, and that actually showed 30% mosaic for monosomy X. So that was a true positive NIPT result. And for the second pregnancy, they came in straight for NIPT, and that was low risk, and they are parents to a healthy baby girl. So what is the takeaway here? Okay, so one thing we have observed in our follow-up data that 11.8% of high-risk patients terminate the pregnancy without confirmation. Now, it's very, very critical to understand that NIPT is a screening and not a diagnostic test, and therefore false positives are possible due to confined placental mosaicism. It could be because of vanishing twin, it could be because of fetal mosaicism, maternal mosaicism, or maternal malignancy. And terminating the pregnancy without confirming the NIPT results can actually lead to a loss of a euploid pregnancy. And also, like one of the further cases will show how analyzing the NIPT result or the further follow-up can actually help you for planning further pregnancies, because you will understand what is the chromosomal condition. Now, this particular information of the follow-up of termination was selected for a lightning talk. This is Shweta Malangam, our genetic counselor, and she presented it at a lightning talk on World Congress for Genetics. So this other case is very, very interesting. I mean, just before this, we had a talk with Dr. Mandakini, and she was talking about a Down syndrome individual who was a father of a pregnancy. This is the mother. There is a 23-year-old woman who herself had Down syndrome, okay, and she was pregnant. She was counseled to undergo an invasive test because for sure we wanted to know. We had several discussions with the clinician, and we said that, see, there will be a huge maternal background. Sorry. Okay, there'll be a huge paternal background which will confound the results, but she was very scared of invasive testing and they did not do an invasive test. They sent an NIPT. Sure enough, NIPT was high risk for trisomy 21, but after that, she was convinced to go for an invasive test and the fetus was actually normal. So in this case, what has happened is that the maternal background has influenced the NIPT result. Sometimes you might get a false positive monosomy X. That is also because of the maternal loss of the X chromosome as a woman ages. Okay, so what is also very important in this case is discussion with the clinician and the lab, and also genetic counseling of the patient to understand that after this you need to go. If you have a high risk result, you will have to go for invasive testing. And since the significance of confirmatory tests was discussed with the mother, they went in for a invasive test. So no irreversible clinical decision should be taken based on NIPT result alone. And a few of these cases were also selected for a lightning talk by another genetic counselor, Angela Devenbo, just last month. So now this is another very interesting case. We do offer basic screening as well as extended screening. This actually came at 16 weeks, 4 days for an unossified nasal bone and mild left axis deviation of the heart. Okay, the fetal fraction was 17.6. It was low risk for all the common chromosomal abnormalities, but we saw a definite high risk for trisomy 22. So we actually spoke to the clinician and told her that this is what we are seeing. She said, yeah, I have a little bit doubt about this pregnancy. Let me call them again for a scan. She called them again for a scan. This was an incidental finding, and she saw that the anomaly actually had progressed and it looked almost like a tetralogy of fallow. Upon counseling, they actually decided to terminate that pregnancy. The product of conception was investigated, which showed 30% mosaic for trisomy 22. So this was a true positive. So NIPT actually is pretty sensitive to detect rare autosomal aneuploidies also. Now, what are rare autosomal aneuploidies? So these are trisomies in chromosomes other than 21, 13, 18, and 6 chromosomes. Now, what do we know about rare autosomal aneuploidies? So if you have 1,000 individuals, you might find them in about 0.35% of individuals. Okay, and the most common that we have seen actually is trisomy 7, trisomy 16, and trisomy 22. And when you see the pattern of abnormalities between NIPT and CBS, you will see that it's kind of similar. So that is again further evidence that the cell-free DNA actually is coming from the placenta, and the POC pattern, as you can see here, is different. Okay, so what is the outcome? Suppose you have a high risk of rare autosomal aneuploidy on NIPT. What is the outcome? Now, the literature, there isn't too much right now, but some of the major papers say that you will end up in normal live birth in about 50% of individuals. But about another 50% who have shown high risk on rare autosomal aneuploidies may show miscarriage, may show malformations, may show intrauterine or postnatal growth restrictions, and also intrauterine device. So like I said, 50%, this 49 is at about 50% of individuals may result in normal live births. So this is also called as expanded NIPT screening. There are certain benefits because sometimes there is test failure because there is abnormality in another chromosome. So those can be resolved. Okay, then these actually become high-risk pregnancies because of this chromosomal abnormality, because the most common thing is that these abnormality will actually be confined to the placenta, and the fetus may actually be karyotypically normal, and but it does have implications on the placental function. Usually we see fetal growth restrictions. Okay, so what is the disadvantage is that genetic counseling becomes very, very difficult in this case, because we don't know exactly whether the fetus is full blown, will have it, whether the fetus is a mosaic, whether it is just confined to the placenta. Unless you test it, you will not know. And it can lead to additional invasive procedures. So as such, genetic counseling is complex because of uncertain pregnancy outcomes, because of false positive rates, and also there is also always a possibility of finding a maternal malignancy. So far, the ACFG or any of the guidelines do not recommend doing RATs or rare autosomal aneuploidy testing by NIPT. Now, there was one other case, very interesting. So this is what are the tests that you should do once you have a high risk on NIPT. These are very rare case scenarios, but something which we should keep in mind. So it was a 34-year-old woman who had spontaneously conceived. It was a 12 weeks, 5 days gestation. And NIPT actually showed high risk for trisomy 13. The confirmatory test, which was first done, the FISH result actually showed 10% of the cells which had trisomy 13. The QF-PCR result was normal. The microarray was also normal. Okay. Then finally, when the karyotype actually resolved the issue, because when they looked at 30 cells, they found that 10 cells had a presence of extra chromosome 13 and a derivative chromosome 13 formed by Robertsonian translocation between 13q10 and 14q10, and 20 cells with derivative of chromosome 13, this one. So these type of pattern is something which can be picked up only by a karyotype, and this does have it. Probably one of the parents may again be a carrier. So again, the parental testing will be needed in this case, and it is also necessary for further counseling of what will be the outcome of their future pregnancies. So sometimes more than one test may be needed to understand case scenarios, and each test has their strengths and weakness, and karyotype sometimes is extremely useful for these abnormalities. Now let's get into other relevant aspects. The frequently asked questions are about fetal fraction. So what is the minimum fetal fraction that is needed? So different labs will have different cutoffs. So about 2 to 4% is something which is appropriate, and or so far. And when the fetal fraction is higher, you have more confidence in the result. That is universally true. And about 3 to 5% of cases where you're repeatedly getting low fetal fraction may be associated with aneuploidy. And most of the guidelines recommend that fetal fraction be recommended on put on the NIPT report. So when you look at NIPT report, keep an eye out for the fetal fraction. So we know that fetal fraction decreases with maternal weight. Okay, so this should not discourage you from offering NIPT to obese women or overweight women. You can only kind of add in a line by saying that it is possible that you might need to do a redraw. So we have always noticed that the compliance is much better when you warn them of this. And the other thing, fetal fraction increases with gestation age. As we see, most of our samples come around this stage, about 14 weeks onwards. And another frequent question I'm asked is it okay to do NIPT at 24 weeks, 26 weeks? So technically, it is feasible. We can do it, we can get the result. But if it is high risk, of course, the further cascade of information and how you are going to manage the counseling and further testing is something which you would need to decide. So what about NIPT in twins? This is another question which we are frequently asked. So we know that 3% of all pregnancy are twins, and incidence is increasing. There is a higher rate of complication with twins, and also the biochemical and combined screening has a lower sensitivity. And twins, of course, ultrasound has to be done early for accurate assessment of the twins, and many women we know do not present early. So, and we also know that invasive testing in twins has a higher rate of miscarriage. So, so how well does NIPT work in twins? There has been a meta-analysis in 2019 by Gill and company, and they have found the sensitivity of 98.8% for 21, 93% for 18, and 75 for 13. So as such, guidelines initially did not have much to say about twins, but of late from 2018, 2019, they have been saying that NIPT can be recommended in twins. And the recent 2020 statement says that it is just as sensitive in twins as it is in singleton pregnancies. So what has been our experience? About 2% of our samples are twins. About, as expected, 1/3 are spontaneously conceived and 63% are assisted. And there is a slightly higher chance of having no call with twin pregnancy, which is about 4.3%. And we've had 3 high-risk cases, which were high risk on NIPT, and 2 of them, which were further tested, were true positives. So what is the summary in twins? The risk is per pregnancy. The high risk result requires confirmation. You cannot tell which twin is affected, and a low risk low risk has a very high negative predictive value, just as with singleton pregnancy, and it requires a slightly higher fetal fraction to make a call, and we cannot test for anything greater than twin pregnancies such as triplets or quadruplets. Now, I'll quickly go over the current limitations. We know that you can have false positives, though it is very low. You can have false negatives, which is the most dangerous scenario. Some of the times the test may not be reportable. Recently, we had one case from CMC Vellore where we realized that the lady had SLE. First time the QC failed. Second time we knew. I mean, we didn't know initially the first time. Second time we knew. I mean, this information, if it is provided on the requisition form, it is useful. So we can expect it. And the other thing on heparin treatment also, but there isn't conclusive evidence that it lowers fetal fraction or the disease itself has an impact. Then sometimes there may be incidental finding. We have had one case of maternal neoplasia, and also unintended things you can pick up. So this is one of my favorite slides because it very well explains how you can get false positives and false negatives with NIPT. As you can see here, this is your single zygote, which is dividing. One of the cell has become trisomic. So if that then multiplies, and it is restricted only to the fetus in this case, okay, in the inner cell mass, only the fetus will have the abnormal cells, but the placenta, which develops from here, will be normal. So this is the most dangerous scenario in which you will get a false negative because the cell-free DNA comes from the placenta. Okay, and these are the other scenarios in which you will get false positives because just the placenta has abnormal cells, but the fetus is normal. This is still an okay outcome because even if you have undergone invasive tests, the fetus is normal, so they continue with the pregnancy. And in this case, here is when you will get a true positive result, and this is a normal fetus. So one other thing which I've always asked about, vanishing twin pregnancies. Okay, so even today I spoke about vanishing twin pregnancy. Now, in general, we would discourage NIPT in vanishing twin pregnancies. This was a case which came at about 37 weeks. There was vanished twin at 6 weeks. So we had this about 11 weeks later. Even 11 weeks later, we realized that there is a possibility of triploidy or vanishing twin. So you see that 11 weeks have passed, but still there is DNA from that vanished twin which is circulating. Okay, so this type of result you can only get with SNP based, but when you have a counting based technique, we can't actually tell. So we might just give a whatever the result may be, low risk or high risk. And this patient again came at 24 weeks of gestation, and then we were able to give a result because the DNA from the vanished twin has disappeared. This is what is understood. So you see, the time duration is pretty long, and therefore, whenever I get calls for vanishing twin, usually I discourage. So the reason is that the DNA from the vanished twin may still be there, and that can confound results for the current pregnancy. So this is a literature evidence by Karnau 2014, which said that from fetal demise, you can actually detect the DNA up to 8 weeks also. So, vanishing twin, should you do NIPT or not? We should be very careful. There is a high possibility of false positives, probably the twin which demised, probably because of an abnormality. The guidelines actually discourage vanishing twins. And in counting method, there is no way of knowing whether you are analyzing DNA from the vanished twin. So we will also be in the blind. So usually if they insist and it's a very precious pregnancy, we do it after a gap of as much as possible. And there will be a disclaimer of the possibilities of reduced sensitivity. And coming to best practices, you have to make sure that the test that you're doing is validated. Genetic counseling is of great importance. I mean, many times the clinicians themselves do the genetic counseling, and now there are also genetic counselors available to kind of explain the test, and also what are the type of reports which you can expect. You can get low risk, you can get high risk, you can get a no call, and what you should do in each of those scenarios. How the blood has to be collected properly, instruct tubes, the processing in the lab, the reporting, and the QA. Now, like I said, pre-test genetic counseling is extremely important in NIPT. So I understand that as clinicians, most of you will be very, very busy, but a few key points are something which need to be conveyed to the patient. And also once a result comes, what is the, also very, very important is that NIPT only looks for risk for conditions that we are looking for. Doesn't mean that if NIPT is low risk means everything is fine. This can be a misconception in certain areas. So this is one thing. So we are only looking for whatever the test that has been asked for. So I'd like to conclude here. NIPT is a very sensitive and specific test for assessment of common chromosomal abnormalities, both in singleton and twin pregnancies. The greatest advantage is that it significantly reduces the need for amniocentesis and its associated risk or other invasive procedures, and high negative predictive value gives great reassurance to the parents, and the jury is actually still out for expanded screening or for rare autosomal aneuploidies, and both pre and post test counseling is extremely important for any genetic test for that matter, especially NIPT, and it can be carefully integrated into your prenatal practice. So I'd like to thank my colleagues, and it's hard work of everyone which brings you the tests. Thank you so much.
Yeah, great. That was excellent deliberation. Hope there will be an amount of questions which has been answered, and questions that will raise the eyebrows. Specifically, those autosomal recessive condition like trisomy 22 that you looked into, you incidentally finding. The next is this twin. This vanishing twin fetal DNA remaining up to say 11 weeks is something normally fetal DNA disappears immediately after delivery. But here, because this fetus which is demised is still there, so that the placenta is likely to send some amount of DNA into the circulation, and that's probably the explanation of fetal DNA circulating after 11 weeks still in the maternal circulation. So vanishing twin testing by NIPT is real challenge, and you have explained it well. Thank you, Dr. Priya, for that deliberation and sharing your experience. Actually, sometimes we do see patients of NIPT having a positive report without doing an invasive testing, go and get that pregnancy terminated. Those who have joined are getting these patients done. Please do not encourage them to terminate a pregnancy. Still, there is a chance that there could be other possibility of NIPT being positive, and hence it is a screening test which has been emphasized time and again. It has to be followed by an invasive test if it comes high risk. So that was great, and we hope some questions in this on this topic. So we next move on to the next speaker, that is Dr. Meenakshi Lallar. She is a geneticist in Chandigarh, well known, attached to many infertility centers. At least few of them I know. She was formerly the associate consultant in Institute of Medical Genetics and Genomics, Gangaram Hospital, New Delhi. She does a lot of reproductive genetics, prenatal diagnosis, and molecular genetics. She is one of those who have interest in doing genetics in reproductive medicine. So I am thankful to Dr. Meenakshi to agree upon to talk on this topic, which is interesting for the common clinical practice, day-to-day practice, specifically in infertility. Thank you, Dr. Meenakshi, and over to you.
Very thank you, ma'am, for the kind introduction. And I would like to share my screen. Just share screen. Yeah. So, am I audible, Joseph?
Yeah, Dr. Meenakshi, you're clear and audible. Please go ahead.
Okay. So very good afternoon, everyone. So I'll be going ahead with the second talk for today, which is genetics of infertility. And it is very important for all of us because, you know, infertility is not an uncommon scenario in our clinical practice. And this is going to be the framework of my talk. So I'll be starting with the male and female causes of infertility. And what for the ease of the talk, I'm going to divide it into the cytogenetic and the molecular causes. And we're going to discuss a few case scenarios. And finally, what the carry home message should be, what actually we should be doing in our clinics. So the causes of infertility, if I would like to start is that the causes of infertility is around 30% male factors, 30% female factors, and combined factors in around 10%. And in around 30% of the cases, it is unexplained. We do not know what the reason is. And but yeah, we do know that in these cases, it could be a genetic cause. So we all of us know in basic obstetrics, there is a basic workup that we do. Always the history and physical examination is very, very important. And then there are certain basic female and male tests which we need to do. We have to ask for a normal menstrual cycle, the tubal patency, the ovarian factors have to be ruled out. The husband semen analysis is very, very important. And the genetic factors are though very important, but we should always keep in mind the common conditions as well. So the genetics is as a second line, but a very, very important conditions. So if I go on to my genetic databases and I put in the word infertility and I see the number of hits I get, so there are around 4,000 entries with female infertility. That means there are around 4,000 genetic conditions which are associated with female infertility. And similarly, there are even more, around 5,000 entries with male infertility. So that tells us there is a large monogenic genetic burden of infertility. Right. So I'm going to be starting with the male infertility first, and then we're going to discuss the female infertility. So in the males, as of now, according to the literature, 15% are the genetic causes. and there is still an idiopathic group of about 25%. And as our research is progressing and our technologies are improving genetics, we are bound to think that this idiopathic is also a part of the genetic spectrum only. So male genetic infertility is actually much more researched and than the female part, and it is more infertility of males is known as compared to the females, because the thing is that in females it is more of oligogenic, polygenic and multifactorial as well. So if I have to easily classify male infertility, the genetic causes, the 15% genetic causes, so I would divide it into the hypothalamic pituitary axis dysfunction, the genetic causes of this, like the hypogonadotrophic hypogonadism, which we are going to discuss later on. The second would be the qualitative spermatogenic defects. There are certain, when you look at this sperms, if there is a particular shape of the sperms, a particular head anomaly of the sperms, then these anomalies, they are very specific for a particular gene. So though they are very small in number, but very particular defects can lead to a very particular diagnosis, and these are usually very private mutations. Like, these are not a very well-known scenario, but they occur in small consanguineous families over and again. Then the third is quantitative spermatogenic defects. These are the most important. So when we do a semen analysis, if we get a azoospermia or we get oligospermia, so that it's very important. And the fourth is ductal obstruction. So whenever you think of ductal obstruction, aside from the infections, varicoceles and the other things, you should always think about the cystic fibrosis. And now we will come to know that not only cystic fibrosis, there are newer genes which have been associated with ductal obstruction as well. So the obstructed azoospermia also, the genetic testing is important beyond the cystic fibrosis also. So if I'm talking about the molecular, as I'm dividing it into the cytogenetic and the molecular part. So if I am doing a cytogenetic analysis, cytogenetic means I'm looking at the chromosomes, and molecular means I want to look at the single genes. So why I'm dividing it into cytogenetic and single genes is because the test is different. It is very important to realize that there is no single test which is going to give you all the information. And this becomes very important because then you have to go stepwise. There is the compliance required from the patient, the understanding on the patient required. There is a certain timeline which needs to be told to the patient. And when it is done and so there is an array of tests, battery of tests, and one test needs to be chosen depending upon what we are looking for. So if I want to rule out the chromosomal disorders like a Y chromosomal defect or other chromosomal defects or micro deletions, especially if I have a patient who has azoospermia or severe oligospermia, so then I'm going to do a basic karyotype. And if I don't get anything in a karyotype, not exactly microarray is the special design ones, not the general microarray that we do for the fetus or the grown-up kids with intellectual disability, but the long-range PCRs or MLPA for the microdeletion regions. So, but if I am thinking of a single gene defect, like if I'm thinking of the non-obstructive azoospermia, if I have a report which tells me it's a non-obstructive, or on physical examination, or there is absence of the VOS difference, then these tests of the cytogenic tests are not going to help me. So then I have to look for the cystic fibrosis gene. So there the testing is going to be a Sanger sequencing, panels or the exomes. And depending upon the cost effectiveness, the exome would be the preferred test here because it covers a large number of single genes, all the OMM genes depending upon the platform or the number of genes that we are covered. So it is going to give you the least cost and the maximum yield from that. And as Dr. Priya said, the pre-test and the post-test counseling is very, very important because these are such complex tests. The patient needs to understand what the limitations of these tests are before undergoing. When the patient pays for the test and they expect that now I want to get every information. No, that is not possible. There is a test will only look at the things that it is expected to look for. And if we have a patient in whom we are expecting hypogonadotrophic hypogonadism, the FSH, LH levels are low, then also a clinical exome would be a good test. So we are going to elucidate these with the help of examples further. But why do we need to do genetic testing in males with infertility? What am I going to get out of it? The first thing is that there are three main objectives. We want to establish the cause and diagnosis. And the prognosis is going to change, because if I get a male who has a 46XX on karyotype, right? So there I know that this I am not going to retrieve any sperm. So the ICSI and all those tests, they are not for me in that case. But if I get a karyotype report which says that this patient has Klinefelters, it's XXY report. In that early age groups, depending upon the testosterone levels, it shows that in around 30% of such cases, we are able to extract some amount, sperms have been extracted, and pregnancy can be achieved with the ART techniques. And it helps to personalize the therapy, because as you see, or based on the above two examples, there cannot be a mass approach for genetically the males who have genetic infertility. There is no single approach. It depends upon the diagnosis. And it is also very important, in the next generation reoccurrence. For example, if there is a microdeletion in the azoospermia factor C region, and it is that person is going to have a son, so that will be transmitted to his son. So that becomes important. And sometimes we even want to do prenatal diagnosis, because some of these individuals, studies show, have a higher risk of having Turners or aneuploids. So it's really not confirmed, but in some cases you might want to do amniocentesis after ART. So again, just re-emphasizing the same, that if I am looking for the cytogenetic, I am focusing on the chromosomal defects and the microdeletions, and the tests would be karyotype, FISH, or the long-range PCRs, microarray, specially designed ones, not the routine microarray. Now, this is very, very important to know the basic structure of the Y chromosome. I'm pretty sure if you are looking at the karyotypes regularly in your clinics, you must be getting those Y chromatin, heterochromatin Y, Q, H plus, and inversion of Y. And those reports sometimes baffle us, especially if they come in a patient who has infertility or who has recurrent pregnancy losses. So you must know the basic structure of the Y chromosome. So Y chromosome has a short arm and a long arm, which is separated by the centromere, and the two blue regions are the pseudo-autosomal regions. Means see, the Y has to pair with X during meiosis. There is no another Y chromosome for it to pair with. So these two will pair with the X chromosome. So that means only this part is homologous to the Y chromosome. So all the orange and the yellow region is different. So the SRY gene is very, very important. It is called the testes determining factor, or the one gene that is required, which is the basic gene which is required for the production of the testes, sperms, and the male organ differentiation in the fetus. So that is present in the P arm. The Q arm, this region has this is called the azoospermia factor A region, azoospermia factor B region, and azoospermia factor C region. So these are called regions, but they have many, many genes. And this has a repetitive region. Whenever the chromosome has a repetitive region, it has a underlying tendency to undergo non-homologous recombination, and as a result of that, there can be deletions and duplications. So this region, this azoospermia factor regions, are very prone to microdeletions. And microdeletions in this region, which are responsible for the formation and functioning of testes, lead to the azoospermia. Right? So the basic structure of the Y chromosome, it clears a lot of doubts, and it helps in the understanding. So we should know it. And see, this is the heterochromatin region. Heterochromatin is a gene poor region. So if heterochromatin, if you see in some reports, it's written YQH plus, YQH plus, means there is additional heterochromatin. That is not going to harm because this doesn't have any gene. It's heterochromatin. So this is not going to have any effect. It is kind of a polymorphism, right? So that's not much of a clinical importance. So Y chromosome in infertility can be changed in structure, it can be changed in number, there can be mosaicism, and also you have to look at the X chromosomes, the number of X chromosomes associated with Y chromosomes, as in Klinefelter syndrome. So karyotypic abnormalities, this is one thing that we should always remember, are more prevalent in oligospermia and azoospermic men as compared to the fertile controls. So every couple with infertility, karyotype should be done. And karyotypic abnormalities are seen in 0.4% of the general population, but in 3.6% of oligospermic men and in 15% of the azoospermic men. So you cannot miss out on the karyotype testing while dealing with an infertile couple. And overall 5% of infertility patients, you can think that you will get the answers on karyotype report only. Okay, so if I send for a karyotype, what am I actually expecting? What I send a patient for a male patient for karyotype, with a patient with infertility, what do I expect? I want to look at the X and the Y chromosomes. There can be Klinefelter syndromes. That is one of the commonest reports that we get. So it is due to additional number of X present, and it could be mosaic or it could be a non-mosaic, and it could be rarely a Jacob syndrome, but they usually have a normal fertility, but rarely you can come across it. It could be a 46XX male. They have a functioning SRY gene due to translocation on the second X chromosome, and that is how they have the Wolffian structures differentiated in them. So this is what you can get, and the prognosis changes because in Klinefelter you can still give a hope that we might retrieve some sperms. In Jacob syndrome, you can tell them that almost normal fertility is expected, but in 46XX males, there is actually no hope for that we would be getting any sperm, so they will not be the candidates for FOGSI, TESI, and all those techniques. The second thing that could be abnormality in the Y chromosome structure. It could be an isodicentric Y chromosome. It could be in Y chromosome inversion, and these are usually familial inversions, and usually they will not mean anything unless and until the inversion involves breakpoint of a gene. Inversion means it's flipping over, unless and until it breaks a gene that is involved in testicular formation and function. And then there can be balanced translocations between X and Y, the Y chromosomes and other autosomes, and between autosomes and autosomes. So that is what I am expecting to look at the karyotype. And again, as we've already there can be different mosaicism, the gonadal mosaicism cases, and in all these cases, it is very, very important to do a good physical examination of these patients, because you will get some telltale signs like in hypoandrogenism, tall stature in Klinefelter, gynecomastia. You might get the ambiguous looking genitalia, hypospadia. So a good physical examination is a must. So all this thing is going to change. The techniques that we want to use for the genetic counseling is very, very important. And in some of these cases where the prenatal is possible, like in cases of Klinefelter or Jacob, you might just want to, tell them that, yeah, their literature has reported very rarely some sex and the other aneuploidies in amniocentesis may be opted. So the most frequent chromosomal anomaly in non-obstructive azoospermia that we all get is Klinefelter syndrome and the variants. It could be a plain Klinefelter or the mosaics. And the most frequent chromosomal anomaly in non-obstructive oligozoospermia are the structural autosomal translocations. So karyotype is a basic thing that should always be done. Then Y chromosomal microdeletions. The microdeletions are not seen on karyotype. So, okay. So if you are getting a normal, if there is a patient with semen analysis with azoospermia and you get a normal karyotype, you do not stop there. You have to go for a microdeletion analysis. So microdeletion, what are the microdeletions? Again, going back to the Y chromosome structure. So this region, the azoospermia factor A, B, C region, has many genes which are involved in testicular formation function. And this region, as I told you, it has a tendency for non-homologous recombination, and it leads to recurrent microdeletions. So, and the thing is that if there is when do you test for the microdeletions? Following sperm analysis, obviously it is seen and you will get a positive report in 10% cases with non-obstructive azoospermia, 5% with severe non-obstructive oligospermia. And why is it important to do it? Because okay, if I do a Y chromosome microdeletion in a patient with azoospermia or severe oligospermia, and I get a deletion in factor A or a B region, then there is actually not much hope. There is no hope for a sperm retrieval because sperms will not be found even on testicular biopsy or ICSI. But if I get a deletion in this AZFC region, then we can find retrievable sperms in as high as 70% of the cases. But the important here is that, see, if a male is going to have a son, the Y chromosome is going to be passed. And if we use ICSI in this case, so the azoospermia factor C region might be transmitted. So we have to just sensitize the patient to that. And very rarely in literature, Turner and other sex aneuploidies have been reported. So we might as well want to inform the patient of that. And if they want to opt for, we can opt for amniocentesis, but the risk is really very, very small. So this is how a microdeletion report looks like. So we look at the azoospermia factor A, B, C. We are doing this in our labs. And if the azoospermia factor C region is the one that is deleted, I get the answers to my query that what is the reason of oligo or severe oligo or azoospermia in this case. And this is a good news for the patient because we will be able to retrieve sperms in this patient and in this patient, and they can have a fertility. So the single gene defects, now we are switching our gears to the single gene defects. The single gene defects, when I'm talking about a particular gene, which is there are around 2,000 genes which are involved in the male reproductive system, in the testicular maturation, formation, and the spermatogenesis process. So it is such a complex process, so many genes are involved. And there are certain genes, three in a group I can say very important: AR, the aromatase, the AR gene, the CFTR gene, and hypogonadotrophic hypogonadism causing genes. There are around more than 24 genes under this group. And so these are the single gene defects which can lead to abnormality in the testicular development or the sperm development. And they are identified not by any cytogenetic test, but there is another set of tests for these. So when do you suspect these? If a patient comes on to us who is a male with infertility and he has features of hypoandrogenization, like there is less hair on the body in the Tanner index that we do, and if the genitalia looks hypoandrogenized, there are undescending testes, the male voice pitch, there is gynecomastia, the poor virilization, and the FSH LH levels are low, all those things, then depending upon where clinically it is fitting into, then these are the group that where I would think of the single gene disorders. And also the azoospermia, severe oligospermia would be there. So you might already have done a karyotype and microdeletion for these patients, but here is where the importance of the general physical examination and the endocrinological workup comes in. So it's always very important that a complete thing should be done. Look at the patient completely. again, we've discussed all of this already. So the hypogonadotrophic hypogonadism is actually very important when the FSH, LH, testosterone levels are low, and it is not very uncommon. 1 in 8,000 men, and for us as geneticists, it is sometimes challenging because they have a very variable expression, penetrance, like the mutation is present, but it might express or it might not express. The inheritance is very varied. It might be autosomal dominant, recessive, or X-linked, and that is going to change your genetic counseling. But the very, very important thing is here is that if a male patient has hypogonadotrophic hypogonadism, it is treatable. We give the GnRH pulse therapies, we give testosterone. There can be a sperm production, retrievable sperm production has been documented. So it's actually a treatable cause. One thing is that it's treatable cause. The other thing is that because it is monogenic, it is a single gene defect, it can be transmitted to the next generation. So here comes in the part as a geneticist that we have to counsel the patient regarding this also. That also becomes very, very important. So the same thing is highlighting the same things. And yes, in these patients, a good general examination is very important because, you know, some of these patients will have certain syndromic features, like they will have midline defects, because hypothalamo-pituitary axis, it involves your brain, it involves the gonads. So there are certain genes which, like there could be a cleft lip or a cleft palate. You take history of a cleft lip palate which might have been repaired during the childhood, or there might be other midline defects like hypospadia, the ambiguous, the genital defects. So syndromic features and midline anomalies are very common in cases of hypogonadotrophic hypogonadism. And it's, as already discussed, it is actually peculiar and challenging from a genetic point of view because it is so heterogeneous. And sometimes what we talk most of the times is the Mendelian inheritance. But this condition, it sometimes jumps from the Mendelian to the digenic and the oligogenic transmission. But the main point that I want to stress time and again is that it's reversible using testosterone therapy. That is why we are, there are such few conditions in genetics which are treatable. So this being one of them, we would not like to miss it. So if I have a handful of patients in whom I am thinking of a hypogonadotrophic hypogonadism, and I send testing for that, in around 40% of these patients, we are going to get a genetic diagnosis, which will not only help in the pregnancy, which will not only help in initiating the therapy, but also in genetic counseling, that what was the reason and will it occur again in the next pregnancies or the next generation or not. So yeah, it is very, very important, obstructive azoospermia and cystic fibrosis. That what is obstructive, when I talk about obstructive azoospermia, as a geneticist, I'm always going to talk about the congenital absence of vas difference. It can be unilateral, it could be bilateral. If it is bilateral, I'm more in terms of thinking of cystic fibrosis, and in those patients it will come up again, but in those patients 80% of them will have cystic fibrosis mutations. That's important to test. And if it is unilateral, in those with unilateral, the cystic fibrosis gene is less involved. It is seen in only around 40 to 60%, but in that group the renal anomalies are commoner. So if you are getting a patient with congenital absence of vas difference, unilateral with renal anomalies, it might not be cystic fibrosis, but still it's worth doing the cystic fibrosis gene testing because it will still be seen in around 60% of the men. But the commoner is the bilateral absence of vas difference, and cystic fibrosis gene mutation is found in 80% of those patients. And obviously, how is it going to appear on the semen analysis? You will have a very low semen volume and acidic pH with absence of spermatozoa. So, you know, even a single simple semen analysis report is going to give you so much of information in that regard. So overall, if I talk of it as a group of patients with obstructive azoospermia, 6% are going to have CFTR mutations. So congenital absence of vas deferens, we've already discussed. Unilateral, bilateral. Bilateral men will have 80% cystic fibrosis gene mutation. So we don't want to miss out on that at all, because it is important for this pregnancy. They can have ICSI. It is very important to test the female partner as well, because it is an autosomal recessive disease. And there was a very wrong notion, or it was an ignorant notion amongst us, that cystic fibrosis is a Western disease. It's not in India. But through the carrier screening results, we've come to know that India also has a higher prevalence of cystic fibrosis. And now, but cystic fibrosis has such a, such a phenotypic heterogeneity. It is such a varied presentation that it is missed. So we must test all the males with obstructive azoospermia with absence of vas deferens, unilateral or bilateral, for the cystic fibrosis mutations. And okay, if we go for cystic fibrosis mutations, what should we go in for? We are typically looking that I should find two mutations, because it's an autosomal recessive disease. So one mutation is usually the milder one and the other is severe. And usually one mutation is the delta F508 mutation, which is the commonest mutation found worldwide, 80%. The second is the introns. The other mutation is the intronic mutation. We call it the 5T, 70 or the 90 allele. So if you are sending we are doing it routinely, but as a clinician, if you are sending for a cystic fibrosis, you should know that all these intronic mutations should be covered in the panel or the wherever you are sending the sample to. And it is if the person has cystic fibrosis, the female partner should be screened. If she is a carrier, then there is a chance of the child being affected with cystic fibrosis. You give the baby, you give the couple a child, but there's 50% chance of that child having cystic fibrosis, which is a fatal disease and not treatable. So that's going to be very, very bad. So female partner must be tested, and renal imaging is very important, especially when it is unilateral congenital absence of vas deferens. See, so because we know the recent information has shown that in 20% of the bilateral cases and 60% of the unilateral cases, we do not find any cystic fibrosis mutations. So there's a new gene, ADGRG2, which is X-linked, which has been found. It is highly expressed in the efferent ducts. So this should also be tested along with cystic fibrosis. There is another gene, Claudin2, which has been found out. So, if you go gene by gene by gene, it will become very cumbersome. The testing prices will increase. So the best is that we offer is clinical exome to the patient. And I'm going to elucidate it with the help of a case also further in the talk. So qualitative defects on the semen analysis, the genetic testing. So as we discussed in the beginning, if there is a macrozoospermia, globozoospermia, or there are flagellar defects, there are certain group of disorders that you can think of. So a simple semen report, the morphology of the sperm also can sometimes guide you towards what the testing should be. And in all these conditions, clinical exome is going to be, or a panel if available covering all the genes, would be the best test and the most cost-effective approach in these cases. And why do I want to do the genetic testing? Because that is going to end the odyssey for the patient. It is going to give the diagnosis that okay, you have this mutation, we will not be able to help you with the pregnancy. You go for the donors or you go for whatever approach, and if there is something like CHH, we will be able to help you with testosterone and the pulse therapies. So this is going to prognosticate the further for the patient. Secondly, it's going to tell that okay, your children are not going to have infertility or any such problem. So it is important and rewarding. There are again the systemic diseases with male infertility. Myotonic dystrophy is very important. Kennedy disease is important. So this is just a list of diseases. So the basic idea here is that when a male patient with infertility comes to you, look at the patient as a whole. Try to take history and examine the patient as a whole. If the patient says he's very tired all the time, there is muscular weakness, then myotonic dystrophy is one of the very commonest muscular dystrophy genes, and they have infertility. It changes everything. And if the patient is slow, you see polydactyly. If the patient has retinitis pigmentosa and polydactyly, then it changes it to Bardet beetle. Everything changes. It's an autosomal recessive disease. So the idea is to look at the patient as a whole, to take in the whole picture. So when and what genetic testing to do in male infertility? So let us close it here in the males. So I want to look at the Y chromosomes. So I want to look at the X chromosomes, the numbers. I want to rule out Klinefelter in azoospermia. So I want to order a karyotype. Right? If my karyotype is normal, I want to look at the azoospermia factor A, B, and C regions, the microdeletions. I will either order MLPA or the long range PCRs for that matter. If there is hypogonadism, the FSH is low, LSH is low, there is less virilization, the high pitch voice is there, and other clinical telltale signs, then I would like to look at all those genes involved in the hypothalamo-pituitary axis. And then I would want to go for a clinical exome, preferably, because it is going to be cost effective. And before all these tests, the pre-test and post-test genetic counseling is very, very important to guide the patient about the yield of these tests. The second thing is, if I get a semen analysis report with obstructive features, obstructive azoospermia, I cannot miss upon my cystic fibrosis. And if it is negative, there are certain new genes. So as here also, the panels in the exomes might help us, because it has become actually more cost effective that ways nowadays. And if I talk as a whole, in taking this approach, I am able to get my diagnosis of a genetic cause of infertility in around 20 to 50% of my cases, which will help not only in the treatment, but also in counseling for the progeny to that patient. These are the guidelines. These are very old guidelines, but they still remain very true. Again, from the a very recent paper, you cannot miss upon the karyotyping, the Y chromosome microdeletions, and this is CFTR gene deletions. So this I've just put in a very recent paper. So what this group did was that they had around 12 patients who had a normal karyotype, they had a normal basic workup. So they were thinking that there is some genetic cause of infertility. So they did these panels. They made a custom made panel, and they did NGS or next generation sequencing, and they were able to get answers in 10 out of these 12 patients. And in most of these patients, there are abnormalities in flagell or the sperm dynin genes, sperm motility genes, which might not manifest in the semen analysis, but it really helps in the counseling part of the patient. It ends the diagnostic odyssey. So it just shows that it is maybe it is time, after good counseling of the patient, that we can offer higher genetic testing like clinical exomes to the patient, but only after the basic workup is done, a good history, physical examination, karyotype and the microdeletions, and if obstructive cystic fibrosis and everything should be ruled out. Same. Now we are coming on to the female infertility part. The female infertility, if I divide it into the different ranges, one of the common causes are the anovulatory factors. The PCOS is a very, very big commonest thing here. Ovarian reserve depletion, uterine factors. But in all of these, the underlying genetic etiology is there. So female infertility also has a very important role of genetic testing. So if I want to classify it genetically, so there are genes which are regulating ovarian development, which are regulating the maturation of oocytes, the fertilization competence, the pre-implantation development, implantation of the embryo, early fetal growth. All these female genes are important in all these steps. So if there is mutation in anywhere in these steps, it is going to cause infertility. Even premature ovarian insufficiency or failure is very, very important cause of female infertility. Like, then there are many syndromic conditions, and then there are mitochondrial causes as well. This is a very a good reference paper, as well as a very good diagram to show you. see, these number of genes are involved, and if and it starts when the female child is still in utero. If the fetal ovarian development is abnormal, and there are so many genes involved, and if it is due to Turner syndrome, or if it is due to X chromosome structural abnormality or translocations, these genes are not going to function properly, and this is going to lead to either DSD or gonadal dysgenesis or streak gonads. If there is abnormality in the genes of oocyte maturation, this is going to happen around puberty in the female. So if this group of genes is involved, then it is treatable with gonadotrophic stimulation. This is such a nice thing for the patient, a treatable cause of female, genetic treatable cause of female infertility. But if these group of genes are involved, which help in conversion of a primary follicle to a secondary follicle, then they will not be treatable. And this group presents as decreased ovarian reserve, or a primary ovarian insufficiency, or menstrual irregularities. Then even when the zygote is formed, embryo has to implant, or the placenta and the fetus have to start functioning, there are a lot of maternal genes which have to regulate this. So there are so many genes are involved, and it is such a finely tuned process that and in the coming years we are going to have much clarity on all this. But still, there are so many genes which can lead to this, and we can give answers to the patients. Again, same question, why do I need to find the genetic cause of infertility in females? Again, I want to establish my cause and diagnosis. I want to prognosticate the patient before ART. I want to personalize my therapy, and especially fragile X. We cannot talk about female infertility and not talk about fragile X premutations. There have been recent studies which show fragile X is such common scenario in our communities. The common genetic causes of female infertility, as in male infertility, we have to remember our chromosomes first. It could be a chromosomal involvement. I get a patient who has primary amenorrhea, short stature. I think of Turner syndrome. I get a married woman, short stature, she's not conceiving. And again, I do a basic karyotype and I get a mosaic Turner or a Turner. These women can, have some degree of menstruation also. Either withdrawal bleeding they might have, or they might have ovarian failure kind of a picture initially. So it's very important that the chromosome is done, or better yet, a FISH is done. FISH is going to give you the mosaic, the degree of mosaicism that is going to give you. Then the chromosomal balance translocations, because they can disrupt the genes which are scattered through the genome, which are important in female infertility. Then there are single gene causes which are important in premature ovarian failure. Complete androgen sensitivity syndrome. It looks like a phenotypic female, but when you do karyotype, it's XY. And then you think, oh, it's a CAIS patient. Then hypogonadotrophic hypogonadism, just as in males, the HPO axis is immature. The various genetic syndromes in females. So you have to look at the patient as a whole. And the female reproductive tract abnormalities. We see so many patients in our OBG settings with MRKH. We label them as MRKH. We say the uterus is very small, infantile looking on ultrasound. She is having a primary amenorrhea. All these are, there are genetic causes behind of all of these. And with the advent of these newer generation testing technologies, we are picking them up. So karyotype is for all in female infertility, and what to expect. It could be a Turner's, it could be a triple X. Usually triple X retain fertility, but they are usually incidental pickups. Then 46XY females, they will not have fertility. Then there could be various gonadal dysgenesis with mosaicism. Then mosaicism of all the above cell lines can be seen. Then there are certain deletions, duplications of the X chromosomes. So in female with primary amenorrhea, certain telltale signs on physical examination, when you get a karyotype, you might want to go for a microarray. In them, I have not talked about microarray in a male with infertility, but in female with infertility, you might as well want to go for one. There are X autosomal translocations and other chromosomal balanced translocations between the autosomes. Then the X, P, and Q deletions and duplications become important when I'm talking about infertility. So if there is a deletion beyond this region is critical for the ovarian function and maturation, and it is, very near the centromere. So that this can present as primary amenorrhea. This region has the genes that are important in the puberty, the oocyte maturation. So if this is deleted, the area beyond this is deleted, it can present as the premature ovarian failure. But if it is beyond this, then we are not worried about the female infertility. Then we are worried about more of the monogenic causes like the DMD, hemophilia, whatever genes are residing in these places. So sometimes these small deletions are not picked up, but depending upon the size by the karyotype, this might be picked up, but sometimes these and these are not. So here the microarray in a female will be helpful. Now coming on to primary ovarian failure, it is very, very important. The X chromosome numeral and structural anomalies are there. Primary ovarian failure affects 1% of the women, and it can have a genetic cause, like it could be a gonadal dysgenesis female, it could be a mosaic Turner female, it could be a female with X chromosomal copy number variations. Very, very important. If you are thinking about premature ovarian failure, always rule out fragile X. Now there we have so many, more than 40 genes we have which are responsible for premature ovarian failure. So that is very important to screen, to prognosticate the patient. So 1 to 2% women are affected by premature ovarian insufficiency. And this means that they are stopping their menstruation before 40 years of age. They have a very high FSH and LH level repeated on twice the occasions. They have medical risks of high osteoporosis and cardiovascular genes. In such women, do a karyotype, do a fragile X testing, and and we need to test all the single genes. And also you need to a very good physical examination. This is these are our chromosomes, 22 chromosomes and the X chromosomes. This is a haploid we've shown, and the red dots are all the genes regions that are involved in premature ovarian failure. So see, it is a genomic picture. There are so many genes that have to act together to regularize the female reproductive system. So a lot of the genes are involved, and so a group of single gene testing has a good yield in these cases. So these are all the studies that have been done since 1998 to 2008, and they show that in a group of female with premature ovarian insufficiency, X chromosome defects are seen. So I'm going to do karyotype, deletions are seen, and see all these genes. Because the NGS technology evolved around this time, so we are finding more and more single gene disorders. So depending upon the thing we are thinking of, a karyotype, a microarray, fragile X testing, and the panels or the exomes will give us the answer. A stepwise approach is required. Again, coming on to the hypogonadotrophic hypogonadism, what am I going to think? When am I going to think about it? A patient comes to me with primary amenorrhea. She doesn't have short stature. She is a well-built, good-looking girl. She has a low FSH, LH though, and a small infantile-looking uterus. We all have encountered such patients in our OPDs. And then because I'm thinking her FSH, LH are low, because then I think that the axis is not mature. So I'm thinking in terms of hypogonadotrophic hypogonadism. And then I ask her the sense of smell. This is ingrained what we read, but most of them have a normal sense of smell. And then we are going to ask for the family history in these cases. This is important because we'll discuss a case later on. Then we also have to think of genetic syndromes that can be associated with infertility. Fragile X is very, very important. So I'll be dedicating a good 2 slides to Fragile X. Fragile X and female infertility. When do we test for Fragile X? When do I start thinking of Fragile X testing in a female patient? When there is obviously a family history of intellectual disability, when she is already, it seems to you that the patient is borderline IQ or a bit slow, when there is premature ovarian failure, absolutely everything is okay. When you are considering, when you are giving ovarian stimulation in your ART cycles and it is not giving you the optimum results, poor results, so then also you test for Fragile X. And why is genetic counseling important here? Because, there are levels of mutations in Fragile X. It could be a normal, it could be a pre-mutation or a full-blown mutation. And if a woman is a pre-mutation carrier, she can have an affected son. So that is very important. Fragile X, what is Fragile X? Fragile X is a gene, FMR1 gene. Fragile X is a disease which is caused by FMR1 gene repeat expansion. This gene is present on the X chromosome, and if the normal, I think I should, yeah. So the normal alleles are 5 to 44. The gray zone is between 45 to 54. Pre-mutation alleles is between 55 to 200, and fill mutation is 200. So this is something I want to screen in my patients, that if it is between 55 to 200, and if it is more than 200 in a male, that child will have Fragile X syndrome, right? But if it is a woman with pre-mutation alleles, she will present as an ovarian failure patient, and she can also have a child with mental retardation. You give her stimulation and she conceives, then her son can have intellectual disability. So that is why the genetic counseling becomes important here. Also, the intermediate gray zone here, 14% of them can actually progress to the pre-mutation allele. So that is also very important from the genetic counseling point of view. Fragile X carrier rate. Why should I be worried about Fragile X testing in women? Because 1 in 150 healthy women are carriers of the pre-mutations, and 1 in 468 men. So that makes it more than 60 million individuals worldwide. Even I was astounded by this figure when I came across in the article. So it should actually be screened for every woman with premature ovarian insufficiency and with the family history of autism. And if you are getting in your clinic 50 women with premature ovarian insufficiency, one will have actually FMR1 pre-mutation. And if this woman tells you that there other women also in her family had an early menarche and difficulties conceiving and all, then that this is going to be even higher. The chances of finding would be even much more higher. 1 in 15, the chances would be of FMR1 mutation, pre-mutation in this patient. Now, just to summarize, genetic evaluation of infertile females, we cannot miss the karyotype. Karyotype has to be done. What are we looking for? It could be a Turner. Okay, if it is not a full-blown Turner, you are not identifying, she's not short, but it could be a mosaic Turner. It could be a mosaic gonadal dysgenesis. She might have a Y chromosome as well. So always look at the genitalia. Always look at the secondary sexual characters. It could be, and when do you do microarray? Don't do microarray straight away in an infertile female patient. Always a karyotype first. And if she has this history of premature ovarian insufficiency kind of a picture, like the periods do not come without withdrawal, or she's having long periods, and you've ruled out the basic things, you've ruled out PCOS and other things, the FSH levels you've seen, and then if it is pointing towards PUI, you might want to do a microarray here. And if your general physical examinations points to in that direction, Fragile X in a woman with oligomenorrhea, primary ovarian dysfunction, as discussed, poor response to ovarian stimulation. And if the FSH-LH levels are very, very low, and she presents to you with primary amenorrhea and all the above things are ruled out, please think of congenital hypogonadotrophic hypogonadism. These women can also, like the men, have midline anomalies. They can have positive family history as well. Take the history of smell and everything, but usually the smell is normal. Then we want to, and if it looks to you that she has you do an ultrasound and you don't find the uterus and the karyotype is XY, then you are looking at the AR, then you have to look at the AR gene. Cystic fibrosis gene is not done directly in women. It is only done when the husband is found to be positive, because then it is done for the prenatal diagnosis type point of view. And panels or NGS are done in case of congenital hypogonadotrophic hypogonadism, as well as in premature ovarian insufficiency. So quickly, I'll be going through 3 cases. So this was a couple who came to me with primary infertility. They had no significant history, and a male partner had non-obstructive azoospermia. Couple karyotype was done, wife's karyotype was normal, and husband had a marker chromosome. So whenever husband will have a marker chromosome in infertile patient, I want to look for the SRY gene. And where am I going to find the SRY gene? On the Y chromosome short arm, YP. So there are fish probes, very good fish probes for them. So those probes will go and attach at YP. So I did a fish, and what do I find is that out of 30 metaphases, 16 were positive for the and the others did not show the SRY gene. So what do we infer is that there was a mosaic loss of SRY. So this, and when we went back and told them, okay, you study more metaphases. So this is what it came out to be, that male partner actually had gonadal dysgenesis, right? It was 46XY, 85% of the cell line, and 46X, 15% based on the FISH results. So here I know that the XY component is there, and the FNAC showed mature spermatozoa. So ICSI was offered and told them that prenatal diagnosis can be done for that little risk of the aneuploidies, but they have a very, very good result outcome. So this patient benefited. They are blessed with a child now. The case 2 is also very interesting. They were a consanguineous couple who came to us with primary infertility. Female partner was fine. There was no significant history, no significant physical examination findings. The basic infertility workup, the ultrasounds, the menstrual history, the tubal test, HSG, and everything was normal. Male, on the other hand, had a semen analysis suggestive of obstructive azoospermia, and physical examination findings shows congenital bilateral absence of the vas deferens. And he also had a history of pancreatitis. I would like to tell you that cystic fibrosis gene is also involved in pancreatitis, and his nephew had cystic fibrosis. Now, this is actually a diagnosis actually walking into your clinic. So genetic testing, we said, why do we do genetic testing, and what do we do here is, I want to test CFTR because there is obstructive azoospermia. Also, he's telling me that there's pancreatitis history. He has a positive family history. So CFTR gene has to be done. And, because it was a consanguineous couple, and because the testing cost will not differ very much, I told them that we can also do expanded carrier screen for you guys. And the pre-test genetic counseling is very, very important before this. And so it was done, and expanded carrier couple screen was done. And here are the results. So the male had this is the most common mutation worldwide. 80% of the cystic fibrosis mutations are these. So he had this, and he had this other one mutation. So it's always the same thing. A strong null mutation, a strong mutation, and a milder one leads to the infertility pattern. But see, the mutations in the mutation in the nephew are different, and wife does not have a mutation. So this person his child will not have cystic fibrosis. So that amniocentesis and CVS for cystic fibrosis are not required in this person. So we identified, so post-test counseling was done, which is also very important. So this was a male with cystic fibrosis. We found 2 mutations, and the reproductive options discussed were ICSI in this case. Now coming on to the third case. So a 16-year-old girl with firstborn to non-consanguineous parents with primary amenorrhea, infantile secondary sexual characters, small uterus, FSH, LH low. We thought of hypogonadal trophism. We just asked the family history. She said her brother had been operated and there was undescended testes. So FSH, LH was low for age. And we were thinking that, okay, brother, sister affected, autosomal recessive, hypogonadotrophic hypogonadism, could it be these genes? So we did a prenatal testing, prenatal genetic counseling, and told them about the NGS, the yield, the challenges and everything. And they went for the testing. And see, this is what we found. This mutation, homozygous mutation, known mutation was found in this gene. And this is very helpful to them. The brother also had the same mutation, and parents were carrier for that mutation. This was very helpful in the post-test counseling. We explained for the sister there would be reduced antral maturation, but we can give her therapy to see if ovulation induction can be done. For brother, in such cases, GnRH stimulation has some yield of the sperm. So treatment options open up after such cases in these, and they get a prognosis, they get the cause of their diseases. And obviously risk of reoccurrence based upon which mode of inheritance is there. Here their partners would be tested for the same mutation, and if partner don't have, then there is basically no risk of reoccurrence. So this is the last slide. So the genetic testing for infertility in our clinics, in both male and female, we should include karyotype. For males with non-obstructive oligospermia, karyotype, the microdeletions, and panel or exome, don't go from them straight away. A good medical thorough examination and stepwise approach is the best. For obstructive azoospermia, cystic fibrosis must be looked at. And in females, in all cases, karyotype. And if you have certain positive family history, positive, some positive examination find the female with respect to the reproductive tracts and a normal karyotype, premature ovarian failure microarray, fragile X premutation testing, and again hypogonadic hypogonaditrism, we go for clinical exome. And the most important thing is a very thorough history, physical, endocrinal examination is must, because that is going to increase the yield of our genetic testing. It should be done stepwise, not all together. Based upon, you should take one line of thought and then process to it. And this really helps us to prognosticate and help the patients in such way. So thank you. It was quite long.
Yeah, it was quite long and exhaustive. Yeah. Thank you, Dr. Meenakshi, for that talk. One question is there anyone can answer, but before that I must tell that in what we need to understand, why she is repeatedly insisting on good history, good clinical examination, and then ordering is the panel that she is talking about, or what she says is a exome or a panel, is all these data is fed onto the computer. The computer selects a set of genes that is to be looked for, and hence if you have multiple features, or say for example you will tell the patient the information that it has short stature, then wave neck, polydactyly, then a set of genes will come out by the computer, and these set of genes are sequenced, which is called as a clinical exome sequencing. I am feeding the clinical data into the computer, selecting the genes, and those genes are being looked into, and exactly like all the coding regions of that genes are looked into. So that is why the information given to the lab is so important by the clinician, and it is called as a clinical exome. The lab doesn't look into all genes possible on this earth. That will take an exhaustive amount of money. Then the yield will not be, or the information will not be very, very accurate. So what we learned from it is, in an infertile couple, let's look into whether male infertility, female infertility. Female infertility, definitely we look for, say, X chromosome abnormality, but if it is not there, then we go for a, say some other features are there, we go for a karyotype, and then subsequently we classify them if hypogonadotrophic hypogonadism, or what is this, if depending on the secondary sexual character are present, absent, and then the next test is clinical exome. In male, it is karyotype, and then subsequently we think about Y microdeletion, and then order for a clinical exome. There are n number of genes that are being identified. As a clinician, we should not remember these genes, and it is next to impossible to remember these genes. It is very wise and it is very easy to remember one test, that is clinical exome. All of you are aware about chromosomal test or karyotype. Now, Dr. Meenakshi showed that nice chart of so many genes being involved. If you want to look into, then order for a clinical exome, giving in clinical information to the lab. And that will help you in identifying cases. And second thing is, this cost of these tests are decreasing day by day. So it is becoming affordable, and many of the patients are being taking up this test. So with that, I ask you to answer these questions. That is one. Dr. Dr. Naresh is asking about his previous child is Prader-Willi-like syndrome, which is detected by doing a microarray, and then what is going to be in his subsequent pregnancy. This is getting these clinical situations are becoming very common in our practice. Dr. Priya?
Yeah. So, yeah, one thing is prenatal testing can be offered for this. From here, I just want to know what is the classification that is given. It is probably likely pathogenic, right? Yeah, it is a pathogenic variant. So for the subsequent pregnancy, you can go in for early testing, for prenatal testing of the you can do a microarray. So next pregnancy, you will be able to give early information. Yeah.
Because definitely in the next pregnancy, microarray should be done, but the risk of reoccurrence is actually very, very low because deletions are actually
so
deep.
That way, Dr. Naresh, this is thank you so much for bringing up this. Very rarely people disclose this in a forum. All these information. It's nice that you have discussed it in this forum. And then second is, it is very reassuring. Prader-Willi-like syndrome is a condition which is very unlikely to recur, and hence the chances of having a healthy baby is very, very high, more than 99%. Still, as a couple, as a parents, you will definitely be have to be reassured and have to be very, very ensured that the subsequent pregnancy is good, and you have got more than 99% chance of having a good baby in future. Plan a pregnancy, and our all the best to you. You may opt for a microarray analysis of the say as early as 12 weeks by doing a CBS in future pregnancy to reconfirm, and simultaneously the same can rule out your common genetic malformation, that is Down syndrome, aneuploidy. Okay, thank you. Yeah, over to Joseph.
Okay, thank you, ma'am. I'm just checking if there are any more questions. I think if there are no questions, then we can probably proceed. So just to remind the audience again that we are, this is the 4th one in the series, and the next one is scheduled for next Thursday, that's the 18th. So our topic is on laboratory genetic tests and ordering and interpretation, part 1. So we'll be looking at cytogenetic techniques, including karyotype and FISH, to be covered by Dr. Hema Purandare. And then we have MLPA and QFPCR by Dr. Pragya Ranganath. So this is our schedule coming up. So
yeah, Joseph, you need to, our chairpersons need to be changed according to this thing. There Definitely. Is a mistake. Anyway, but then Dr. FOGSI, if you have any comments to this, you can please make it.
I think that was a very informative and vast topic. So I think a lot of knowledge has been gained. I think definitely the those who attended would have been definitely gained by that, because that is not only the basics but also the in-depth knowledge into the different aspects has been covered. Wonderful presentation, wonderful sharing of knowledge.
Thank you so much. The next 2 series are on genetic lab test. So those who are really interested into, say, in our day-to-day practice, we keep on sending, say, for example, clinical exome or say karyotype, MLPA. We get a report of MLPA. What is to be done? We are, as a gynecologist, we are really into a mess for that. So if somebody wants to really clarify their knowledge, next the next 2 sessions are on lab-based technique. So we will try to highlight how to collect a sample, when do you send it to the lab? If you keep it in fridge, whether this sample will remain, or how do you collect it and how do you send it? So what is the prerequisites? So that will be probably helpful in our day-to-day practice. So hope we will be more looking forward for that next session. Joseph?
Yes, ma'am. So thank you very again to our speakers, Dr. Priya Kadam and Dr. Meenakshi, for taking time off from their busy schedules for presenting us with these very insightful talks. And also thank you to Dr. FOGSI Lewis for taking time from his busy schedule to grace our webinar and also give us his encouraging words. And also special thanks to Dr. Mandakini Pradhan for taking the initiative and providing us this opportunity to conduct this series of webinars. We hope to have more of these in the future, madam. And also a special thanks to the audience for taking time off from their busy schedules and registering and attending this session. And we will be sending out the recording of these sessions in due course. So once again, thank you everyone, and we hope to see you for our next session.
Thank you.
Thank you, Joseph.
Thank you, Dr.